Everyone. Today we'll touch upon two topics, umbilicus and rectus sheath. This would be a brief discussion and this would help you in answer writing, and also uh, will quickly brush up your concepts, and this would take less than 20 minutes. You can easily watch this whenever you are free. Okay. So beginning with umbilicus. What is umbilicus? It is nothing but simply a scar tissue. And how is this scar formed? You know, scars are formed after injury. So what is the injury here? So you know that umbilical cord is attached to the umbilicus in a fetus. After the birth, this gets detached. So a small wound is formed, and then this wound is healed by fibrosis, collagen tissue deposition, and all this forms this umbilicus. Okay, this is our umbilicus. So what is the position of umbilicus? You can see it lies roughly in the lower abdomen. What is the position in terms of vertebral level? It lies at the level of L3 L4 vertebra. Okay, it can be at L3, between L3 and L4, and at L4. In this image we can see it lies at the level of L4 vertebra. This is an image from Netter's Atlas. Okay, this is very excellent book, not very excellent, it is an excellent book for building your concepts and visual memory regarding to structures of human body, anatomy of different parts. Okay, you should not confuse this with the dermatome. Dermatome is different. Dermatome is the related to the nerve supply of that level. So that is T10 at the level of umbilicus. And what is the clinical correlation of this fact? That pain in acute appendicitis. In acute appendicitis, it is initially periumbilical. The fact is that the pain is periumbilical because this appendix is a structure of midgut, and midgut is supplied by T10 T11, which is the lesser splanchnic nerves. So it is supplied by the lesser splanchnic nerves, and the same dermatome is also present at the umbilicus. So T10 pain gets referred to T10 dermatome, which is the umbilicus. Okay, but later on, as the inflammation gets more severe, then the pain starts getting localized to McBurney's point. Okay, you know McBurney's point. What is McBurney's point? You definitely know that it is, if we draw an imaginary line from ASIS to the umbilicus, this is known as spino-umbilical line. So it is present at the lateral 1/3 and medial 2/3. This is the McBurney's point. You definitely know that. Okay. Then the second clinical cue is that it also acts as a watershed area. You can see here that the vessels, especially the veins and the lymphatics which are present here, do not cross the umbilicus. Okay, so that is why it acts as a watershed area. The vessels which are present below drain in different vessels, and the vessels which are present above the level of umbilicus drain in different levels. And this is the reason why we see a medusa head appearance in case of portal hypertension. This is the appearance. Here none of the vessels cross the umbilicus, but all of the vessels are around the umbilicus. This shows why umbilicus act as a watershed area. Okay, and this caput medusa name is derived from a mythological figure which is Medusa. Medusa had snakes as her hairs. Okay, so this is compared to that it is looking like small snakes which are coming out from the umbilicus. Okay, now we have to learn some facts. This may come as MCQs. So this is ligamentum teres, also known as round ligament. Okay, this is attached to umbilicus, and this is a remnant of left umbilical vein. You can learn L for ligamentum teres and L for left umbilical vein. Okay, then there are other ligaments. This is easy to learn. The which the one which connects umbilicus to the bladder is the median one. Okay, median one is connects to the bladder because bladder is present in the midline. Okay, and medial, it is a remnant of umbilical arteries. Okay, obliterated umbilical arteries. These are just facts, may come as MCQs, and they confuse between umbilical vein and artery. So you must remember this fact that round ligament is from vein. Okay, and the medial umbilical ligament is from umbilical arteries. Okay, there is another clinical cue related to the umbilicus, that surgical incisions are not taken through the umbilicus. This is because of three reasons, mainly three reasons. There are multiple reasons, but there are mainly three. Because first of all, umbilicus has a poor vascularity, so the incision would be difficult to heal, definitely. Moreover, it is a weakness of anterior abdominal wall. Okay, why we say it is a weakness? Because it is a scar tissue, and before that it was an opening which is not that strong as compared to the other parts of umbilical, other parts of abdominal wall. Okay, and third reason is it is cosmetically important. Definitely in Western world this is very important for cosmetic reasons. That's why we say this. Then there are another few other facts, like there is a smiling umbilicus which is seen in ascites and all. These facts you will definitely learn in future in medicine, so I'm not covering that here. Okay, moving out to next topic, which is rectus sheath. So rectus sheath is a more important topic, and there are many chances that you would get a short note on this topic. So, and it's very easy, so you can definitely gain 3 or 4 marks easily out of 5 marks in this topic. So what is the rectus sheath? The rectus sheath is a covering. You can guess from the word sheath that it is some sort of a covering, and this is formed not from the muscles. Okay, this is a confusion that most of the people have, that it is formed from abdominal muscles. No, it is not from the abdominal muscle. It is formed from the aponeurosis of abdominal muscles, and it covers the rectus abdominis muscle. You can get this from the name rectus sheath. Okay, so it covers rectus abdominal muscle, and it is formed from the aponeurosis of abdominal muscles. Now the question arises, what is an aponeurosis? So aponeurosis, it is a sheet made of connective tissue. It is a sheet made of connective tissue, and what it does, it either connects a muscle to a bone or a muscle to a muscle. Okay, here I have not written the definition of aponeurosis, but when you'll get the final notes, I'll write the definition of aponeurosis in that. Okay, so rectus sheath has two layers. Okay, one is anterior layer and another is a posterior layer. This is a famous diagram. You must have seen this and drawn this in your anatomy manuals, and definitely in your exams you must have drawn this. Okay, so this is an easy diagram. In this we can see this is the anterior wall and this is a posterior wall. Okay, so anterior wall has tendinous intersections. These are the tendinous intersections which tightly adhere to the rectus abdominis muscle. Okay, and the posterior wall is not that tightly attached to the rectus abdominis muscle. Okay, now we'll talk about the formation of rectus sheath, but before that we can see the relations of the rectus sheath. Okay, so anteriorly it is present, rectus sheath is just present below the skin, and definitely areolar tissue, connective tissue which is present, and the posterior wall, it is present below the costal cartilage. Okay, and the lower limit of the posterior wall is known as arcuate line. Okay, so this is how we divide it into three parts. Okay, and different layers form the different part of anterior and posterior walls. So divide into three parts. This is the costal cartilage. So above the costal cartilage, this is the first part which we'll study. Then second part is from the costal cartilage to the arcuate line. This is the second part, and below the arcuate line, this would be the third part. Okay. So this is a diagram which shows all the three layers, and you can draw it as such. This is very easy diagram. I have taken this from BD Chaurasia, I think. Okay, so this is an easy diagram which you can draw it easily in the exams. Okay, first beginning with above the costal cartilage. So you can see in this diagram that here there is no abdominal muscle present. Okay, so definitely the posterior wall will be formed only by the costal cartilage. Only the costal cartilage forms a posterior wall. Anterior wall is formed by, this is the anterior wall, which is formed by external oblique aponeurosis. Okay, external oblique aponeurosis. Let's write this. Aponeurosis, external oblique aponeurosis forms the anterior wall. Okay, so anterior wall is formed by external oblique aponeurosis. This is the anterior wall and this is the posterior wall. Okay, moving on to the next section, which is below the costal cartilage and above the arcuate line. Okay, so in this section we can see the anterior wall is formed by external oblique aponeurosis, definitely. Internal oblique aponeurosis splits into two lamina. So the anterior lamina of internal oblique aponeurosis, this forms the anterior wall, and the posterior lamina of internal oblique aponeurosis, the transversus abdominis and the fascia transversalis, all three form the posterior wall. Okay, so this is the anterior wall which is formed by anterior lamina of internal oblique and external oblique, and posterior lamina of internal oblique, transversus abdominis and fascia transversalis form the posterior wall. Okay, and this was the anterior wall. Now let's look into the section which is below the arcuate line. Okay, this was the arcuate line. You can see the section which is below. Here we can see that the wall is slightly deficient. Okay, so posteriorly only one structure is present, which is fascia transversalis, but anteriorly, because none of the layers of the aponeurosis is forming the posterior wall, so all the three layers will form the anterior wall. So external oblique, internal oblique, transversus abdominis, all three of them form the anterior wall. Okay, so this is the way you can easily learn and easily draw, because I think I have a pathetic drawing, but this is the easiest thing which can be drawn, and that's why I have put in an image, because it's too easy to draw na? Okay, let's look into the contents of rectus sheath. What are the contents? So you can see, you can learn it by 2 2 2 2. Okay, so two muscles. What are the two muscles? You know very well. That one muscle you know very well, that is the rectus abdominis. Second muscle is not present always, it is present in some people. This is pyramidalis, which may or may not be present. Okay, then there are two arteries. Okay, what are these two arteries? It's very easy, superior and inferior. The next thing you need to learn is epigastric. So superior, inferior, epigastric arteries. Superior epigastric artery is a branch of internal thoracic artery, and inferior epigastric artery is a branch of external iliac artery. So you must know this. Okay, then there are two veins, which are superior epigastric vena comitantis and inferior epigastric vena comitantis. This will also be draining, like this would not drain, but this would come out from external iliac vein, and would go into internal thoracic vein. Okay, Now we have the nerves. We have two nerves. Okay, you can say two group of nerves. One is thoracoabdominal nerves. Thoracoabdominal nerve is not a single nerve. We say this is a group of nerves, thoracoabdominal nerves, which is from T7 to T11, and then T12 is known as subcostal nerve. So this is two nerves, you can learn it like that. One is thoracoabdominal group of nerves and another one is subcostal nerve. Okay, so this way you can learn the contents of rectus sheath. Okay, then last is what is the use. So it maintains the strength of anterior abdominal wall, definitely. That is why it prevents herniation of the bowel, because abdominal internal intra-abdominal pressure is very high, and when you do activities like weightlifting, coughing, straining while defecation, or in some cases straining while urination, then intra-abdominal pressure is significantly increased, and this is the rectus muscle and the rectus sheath which provides strength to the anterior abdominal wall, that prevents hernia. Okay, that prevents hernia. Okay, then it also checks the bowing means curving, like this, bowing out of rectus muscle during its contraction. Okay, so this in a way supports and prevents the bowing of rectus muscle during the contraction, thus increasing the efficiency of muscle. Okay, this way efficiency of muscle is increased. So we have nearly completed. Now we'll look at some diagrams. Okay, because this creates a visual memory. So this midline structure you can see here, this is known as linea alba, and this is frequently asked. You must not confuse this with arcuate line. Arcuate line is definitely not this, and these are tendinous insertions. You must not confuse these with the arcuate line. This is also not the arcuate line. Okay, arcuate line is the lower limit of the posterior wall of rectus sheath. Okay, so what is linea alba? You can define this as the midline tendinous raphe. If you use these keywords, your examiner will definitely be impressed, especially in vivas. So this is a midline tendinous raphe which is formed by the fusion of aponeurosis of abdominal muscles. Okay, this is the definition of linea alba. You can see in these tendinous insertions. Then this is the cut end of the external oblique muscle, and this is of the external oblique aponeurosis. And here you can see the anterior wall of the rectus sheath. Okay, this is the internal oblique, and you must be knowing this from the direction of fibers. This is the direction of internal oblique fibers, then, and this is the direction of external oblique fibers, and transversus abdominis would definitely be transverse. So that would be the fibers of transversus abdominis. Okay, this is a image in which we have cut off the anterior sheath in this part, and we can look at the muscle along with the vessels. So you can see that these are the vessel here. This is the superior epigastric artery and vein, and here this we can see this more clearly. This is the inferior epigastric artery and vein, which are the contents. And this is so beautiful image of arcuate line. You can see that the posterior wall is deficient below the arcuate line. So this is the fascia transversalis. This is the only structure left. There is no aponeurotic structure in the posterior wall below the arcuate line. Okay, these are the inferior epigastric vessels. We have done this. We can have a look at the medial umbilical ligament, which is the it is the occluded part of umbilical artery. Definitely you must be remembering this. This is artery, medial artery, median to the bladder, and lateral, no sorry, not lateral, the another ligament was ligamentum teres. Ligamentum teres attached to the yes, you can have a look. L for L, left umbilical vein. Okay, okay, now this is the ligament. Here somewhere would be the median ligament. Okay, and the part here I am not dealing with this. This is the inguinal canal and all. This would be dealt in a different video. Okay, Here you can beautifully see the inferior and superior epigastric vessels, tendinous insertions, arcuate line. This is a easy image. This is an easy image you can draw in your exams. Okay, these are images are just to see and feel happy. This is the image you will draw. Okay, here you can see the arteries. Definitely, if you will, when you will study thorax, you will definitely study these arteries, that we could deal in a different combined video of the arterial supply regarding all these arteries. Okay, so this is the inferior and superior epigastric arteries. These are inferior and superior epigastric veins. These are the veins you can see of uh, abdominal wall. Okay, these are present superficially. These are superficial veins. Okay, these are the nerve supply. You can have a look. You definitely, I told you that T7, T8, T9, T10, T11, these are different nerves. Okay, this is not a single nerve. These are collectively known as thoracoabdominal nerves. And you can see this is the T12. T12 has two sort of branches. One is the anterior cutaneous branch and lateral cutaneous branch. Okay, these form like these innervate some part of the rectus sheath, not completely innervate the some part of rectus sheath. So this is the end of this video. Thank you, and definitely I tried to cover important aspects, and I hope that this would be beneficial for you. Thank you.